Thank you. This is a great opportunity for me to present the clinical trial data supporting the use of tricuspid TEER in people with a symptomatic severe tricuspid regurgitation. These are my disclosures. So I want to start out by some work that we've done recently that was presented at TCT 2022, and really is to try to define who are the best candidates for tricuspid TEER edge-to-edge repair. So we had a database from Germany, a fellow that's been working with us this year, and we were able to look at patients that underwent both MitraClip and Pascal in the commercial setting at a center in Germany. And we've developed a score that looks very predictive of outcomes as far as measured by either TR reduction of greater than 2 grades or TR grade less than 2 at the end of the procedure. We chose both of those endpoints. What we came up with in the multivariate analysis is that there are 6 factors that can predict this: the septolateral gap, septal leaflet mobility and tethering, the number of leaflets and morphology as described by Becky Hahn in her Sentinel publication on tricuspid morphology, the predominant jet location, whether it be anteroseptal, posteroseptal, or anteroposterior, whether there's shadowing or image quality difficulties with transesophageal echo, and then the actual TR-Jeff morphology, whether it's either oval or star-shaped. We gave this, it was straightforward for each of these. It was to be 0, 1 if it's moderate, or 2 for complexity. And what we found is that people with a score of 0 to 2 had a very high improvement in their TR reduction severity. And you can see there that that was almost 90% in that population. And those that had a score of 3 to 6 were kind of intermediate, around 75%. And those with a score greater than 6, you can see did okay, but not quite as well. If we use the measurement of TR grade less than 2 or less than moderate, it was maybe about 30%. If we took the TR reduction greater than or equal to 2 grades, it was only about 10%. So moving forward with that data that we published at this meeting, we showed that there was a nice distribution of people with different scores. So I think that was helpful. And we also showed on these ROC curves that it had a high predictive value. Now, this is a population of about 120 patients. Clearly, with the prospective trials that we have ongoing now, more data will be forthcoming, and we'll be able to validate this in larger models. But I think at least provide some broad guidelines into who are good candidates for edge-to-edge repair, knowing that we have other technologies that are also investigational and commercial, some of these in Europe, which is annular reduction and valve replacement. So one of the first things you'll notice about the tricuspid TEER trials is the outcomes are fairly consistent. And TEER is something you'll see me use throughout this presentation. So what I did here was collect all the trials that have been done, and most of them have been registry data or early feasibility studies in the US, some being in Europe as well. We went through the CLASP compassionate use trial, CLASP TR early feasibility, and the PACE registry by Dr. Jörg Hausleiter, which is a multi-center trial in Europe and really is the largest database we have thus far. Then there's the Triluminate registry. These are MitraClip registries, Triluminate pivotal trial roll-in, and then the CLASP TR roll-in, which I had the opportunity to present at TCT 2022 on behalf of the CLASP 2 TR investigators. I'll mention that the Triluminate pivotal roll-in data was presented at EuroPCR and also presented at TCT 2022. So if you look at this, what the very consistent results we see is that TR reduction across all technologies, 71 to 80%, 86% were moderate or less. So fairly similar, and not really a device specific outcome, but overall performing very well in the hands of these operators. Some were first-time users in the compassionate use in the EFS, and others in the roll-in cases are also first-time registry use, particularly in the PACE registry, are people that are very experienced in the use of this inside some of the best outcomes. Historically, if we look at how do people do with medical therapy with TR, and I know we've talked about this at many different venues and meetings, but if you take that group that had severe TR and just looked at 12-month outcomes, you can see that there was a mortality rate of about 60% in this trial. And then out to, the numbers get small, but you move out to even 24 months, you can see that it runs even higher than that. Another interesting study was that reported by Dr. Hahn and Jack, looking at those that underwent MitraClip that also had moderate or severe TR. If you look at the people that had GDMT therapy, you can see that those patients had about a 40% 1-year mortality rate. And if you looked at those that had even MitraClip, but yet persisted with moderate or severe TR, those were around 25%. So removing the MR improved their outcomes, but still left them with a fairly high mortality rate out to the first year. And the reason I show this is because I want to show you what we have thus far in registries. Now, what we're really lacking and what's ongoing is the edge-to-edge randomized prospective multi-center trials, TRILUMINATE, PASCAL 2TR. Right now, we have roll-in data only out to 30 days. We don't have that full outcome data in the randomized cohort. But having said that, we're seeing some good signals here, right? We're looking at 1-year data in these 3 trials here: CLASP EFS, early feasibility, the CLASP PASCAL compassionate use, and TRILUMINATE registry 1 year, all showing mortality rates which are significantly less than what we saw in the medically treated arms in that previous slide I showed. And if you look at the 30-day data, it gives us a high encouragement that the safety of these technologies is excellent, with 0 and 1% mortality at 30 days in these 2 pivotal trial rolling data subsets. What else have we learned thus far from the registries? Again, showing consistency across different technologies. We're having a consistent improvement in KCCQ. Now, this is a measure that I think is a very objective measure with people's outcomes. And it's also a nice surrogate, if you will, for mortality. But almost, hard to explain how it occurred. But what we're seeing here is that a change of 18 points in 2 separate trials with class TR, and 17 points with TRILUMINATE. So almost identical improvement in KCCQ scores. Now, some people may not be as familiar with looking at that score. So I tried to put that into some degree of perspective here. And what we're seeing in this perspective in this trial is that if you looked at partner 1 and you looked at the transapical TAVR arm or the transapical TAVR arm or the SAVR arm here, what we see here is improvement in KCCQ of about 12%, okay? And when we look at the improvement in the core valve trial, about 21-point absolute increase in the TAVR arm. Partner 2 trial, again, about 17, COAP around 12 in the treated arm. All of these line up very well with what we're seeing thus far in the tricuspid trials, as I said, runs around 17. So it looks actually better than partner 1, equivalent to partner 2, and better than what we saw in the COAP trial. So what are the notable findings from these prospective TEER trials that maybe isn't shown in those, what I try to do in summarizing the trials to date? And I just want to cover a few things here. The survival and heart failure hospitalization rates in the class TR trial, remember this was early feasibility. If we looked at survival and freedom from heart failure hospitalization, it was about, survival was 88%. If we took freedom from hospitalization, it was about 80%. So again, very nice result at 12 months in these Kaplan-Meier curves. And if we looked at even the hospitalization rates, you can see that it was about a 56% reduction in hospitalization from the year prior to enrollment to the year after enrollment in this study. As I said earlier, there are some 2 pivotal trials ongoing right now that will answer this question more readily. The roll-in cohort I talked about, I'm going to show you a few more data points from that. That is a randomized trial comparing PASCAL device with optimal medical therapy to optimal medical therapy alone, with a 2-to-1 randomization in that. Composite endpoint of all-cause mortality, RVAD, heart transplant, tricuspid valve intervention, heart failure hospitalization, and the KCCQ score of quality of life improvement. These people all have to have severe TR and have to have symptoms greater than 2 NYHA. The Triluminate trial, also pivotal, has completed their enrollment in the pivotal trial. No data out other than the roll-in at this point in time. Each site had 3 roll-ins, just like it did in the Pascal trial that I showed earlier. And this is also a randomized trial comparing to medical therapy. So what do we have thus far from the data we can glean from these trials? Again, very high implant success rates of 99%, pretty low procedure times, about an hour and 45 minutes. And number of clips about 2 per patient, and as predominantly XT is being used in this trial, but this was prior to the G4 rollout in about 97 patients. If we look once again, high safety signal, only 1 death that we saw in this trial thus far, and other safety endpoints. I just want to highlight bleeding, which has been a little bit of a plague of all of the transcatheter tricuspid trials, not unique to any one device, mainly related to patients that have a hepatopathy and CKD, so they're more likely to bleed, something that we need to keep an eye on in these trials. And I think we're getting better at managing groins with pre-closing these and using figure-of-8 mattress sutures, and then being more rigorous on how we restart oral anticoagulation. There was 1 signal here of single leaflet detachments of 7.2%. Remember, this is a roll-in cohort, so many people are just getting used to the tricuspid imaging, which can be more challenging than mitral, and also getting used to the TriClip device. So something to keep an eye on, but overall at this point, I don't make too much of that, but we need to keep an eye, because I think with all the tricuspid trials to date, we've seen a slightly higher increase of SLDAs than what we see on the mitral side. And I really think a lot of that is imaging and confirmation of leaflet insertion, which we need to be getting more and more rigorous on, and I think we are. This is the roll-in cohort from the Class 2 TEER trial. Again, a pretty good success rate here. Almost 68 patients out to 30 days, 73 patients were in this roll-in cohort. As you can see, 10 out of the 64 patients did not have a successful implant. 8 of those were aborted due to mainly imaging difficulties or challenging anatomy. These are first-time users, again, with this technology, so I think also something that we'll get better information as we move through the actual pivotal trial. The ACE, which is a thinner type of device, was used in the majority of cases, almost 90% of patients. 1.5 devices. Implant time a little longer than what we saw in the Triluminate, but then this is a technology that people probably have no experience with, whereas in Triluminate, many people have done a lot of mitral experience with the MitraClip device. Discharge to home 100%, which is an excellent result in a roll-in cohort. I don't want to go too much in detail this slide, other than nice zeros across the big endpoints of mortality, infarct, and stroke. Severe bleeding was actually less in this trial. I don't think it's necessarily device specific, but maybe a little more attention to the pre and post closure and a coagulation of these patients. SLDA rate was 4 patients, 5.8%. Overall, all-cause mortality 0. Heart failure hospitalization at 30 days was also 0. We put this data together, and I really have the honor of presenting this at TCT on behalf of the investigators. Want to look at how does TEER affect right and left ventricular performance in RV remodeling. And what we see early on, even at 30 days, is the septal lateral dimension actually decreases. TR jet, as you would expect, would decrease. But what we also see is the RV starts to remodel. The RV end diastolic diameter decreases by both of these measures here. We see an improvement in RV stroke volume, so RV function, which I think that's an important thing as we treat people with moderate and sometimes severe RV dysfunction, that maybe leaving a little bit of TR behind is better than putting a valve in somebody that may have more marginal function. Valve is certainly going to give you more complete resolution of TR than edge-to-edge repair, but early signal of nice result there. And what did that also translate to was an improvement in left ventricular stroke volume as well. And the gradients are not really an issue in the tricuspid world with edge-to-edge repair. PACE registry taken from Jörg Hausleiter here. I want to show a couple things here. The main thing to take away, I think, on this slide, SLDA rates very low in a commercialized setting with people that are experienced operators. So now we're starting to look like numbers that we see in the mitral space, and also the high use of the ACE device, even higher than what we saw in the roll-in cohort of the Pascal pivotal trial. Another interesting piece from this as well is that the freedom from death and rehospitalization for heart failure was excellent. Out to 1 year was 67%. And just in conclusion, there's consistent improvement in symptoms across both platforms, MitraClip and Pascal. Safety signals very high. The mitral valve predicate experience with these technologies certainly shortens the learning curve. And we do think edge-to-edge repair will have a high durability rate based on what we know, at least from the mitral experience. It does impact future TTV replacement options, and there are technical challenges of TTE imaging, that including leaflet visualization, including insertion and its effect on TR reduction and SLDA. And the ICE skills, in other words, intracardiac echo, really need to be obtained to address suboptimal imaging. If you're really going to embrace this technology, you need to take the time to learn that as well. I'm a firm believer in that. And prospective randomized trials have reported roll-in single-arm cohorts at 30 days, and the forthcoming randomized data will define the long-term outcomes compared to medical therapy. I'd like to thank you for your attention. Appreciate the opportunity to present these data to you.